a big round of applause to each and everyone behind it, because awareness is something that is very, very important at this given juncture, I would say, because especially in the case of women, പലപ്പോഴും എല്ലാവരുടെയും ആരോഗ്യ പരിപാലനത്തിന് വേണ്ടിയിട്ട് ഏതറ്റം വരെയും പോകുന്ന സ്ത്രീകൾ സ്വന്തം ആരോഗ്യ പരിപാലനത്തിലേക്ക് വരുമ്പോൾ എന്തുകൊണ്ടോ ഒരു പക്ഷേ അവരുടെ തിരക്ക് കൊണ്ടോ അല്ലെങ്കിൽ പ്രയോറിറ്റി ലിസ്റ്റിൽ അവരുടെ ആരോഗ്യത്തിന്റെ പ്രയോറിറ്റി അവർ കുറച്ച് താഴ്ത്തായിരിക്കും ഒരു പക്ഷേ പ്ലേസ് ചെയ്തിട്ടുണ്ടാവുക. അത് കാരണമോ ഒക്കെ പലപ്പോഴും മിസ്സായി പോവാറുണ്ട് സ്വന്തം ആരോഗ്യ പരിപാലനം എന്നുള്ളൊരു ഫാക്ട്. അപ്പം അത്തരത്തിൽ സ്ത്രീകൾ മറന്നു പോകുന്ന നിമിഷങ്ങളിൽ അവരുടെ ആരോഗ്യ പരിപാലനത്തിനെ കുറിച്ച് ഓർമ്മിപ്പിക്കാനായിട്ട് അത്തരത്തിൽ നേരത്തെ ഓർമ്മപ്പെടുത്തലുകൾ ഉണ്ട് എന്നുണ്ടെങ്കിൽ അല്ലെങ്കിൽ കരുതലുകൾ ഉണ്ട് എന്നുണ്ടെങ്കിൽ പലപ്പോഴും പല അസുഖങ്ങളും നമ്മൾക്ക് വളരെ കൃത്യമായ രീതിയിൽ ട്രീറ്റ്മെന്റിന്റെ സഹായത്തോടു കൂടി ഓവർകം ചെയ്തുകൊണ്ട് ഒരു ഹെൽത്തി ലൈഫിലേക്ക് അതായത് വ്യക്തികൾക്ക് തിരിച്ചു വരാൻ സാധിക്കുകയും ചെയ്യും. സോ ഇൻ ദിസ് given context, such an initiative wherein awareness is being imparted to the women, especially women who actually need exposure to the actualities that is awaiting, അല്ലെങ്കിൽ ഇന്ന സാധ്യതകൾ ഉണ്ട് എന്നുള്ള തിരിച്ചറിവിലേക്ക് ഉള്ളൊരു കർട്ടൻ റൈസർ ആയിട്ട് ഈവന്റ് നടത്തുന്നതിൽ അല്ലെങ്കിൽ അതിന്റെ ഭാഗമായി നിൽക്കുന്ന ഓരോ വ്യക്തികൾക്കും ഈ അവസരത്തിൽ പ്രത്യേകം നന്ദി അറിയിച്ചുകൊള്ളുന്നു. And thanks for making me a part of this initiative. I'm so happy to be inaugurating this webinar on the awareness drive for driving women health. Thank you so much for having me on board.
Thank you so much. And I request you to continue here if you have time. Okay, because
Sure.
Yeah, thank you so much. Because these are the most informative sessions. Previous days, I was going through the sessions and it was very informative. So it will be great if you could join or if you can continue. Next, I think we can start with the session by Dr. Anitha Pillai. She is an infertility specialist and laparoscopic surgeon, senior consultant gynecologist from GG Hospital. Welcome, madam.
So warm good evening to one and all attending the session. Respected Muthumani ma'am, respected Ponnee ma'am, respected Dr. Ansar, and all the respected Dr. Thara, and all the delegates and audience. Warm good evening once more. At the outset, let me thank the IRIA Association, AMMA Foundation, AMMA Association, and Swasthi Foundation for giving me this great opportunity to present before you an important topic regarding breastfeeding and breast cancer risk reduction. As you all know, the month of October is celebrated as the Pink Month, which creates breast cancer awareness. Every woman... Hello? So every woman...
mute except Dr. Anitha. Okay, madam, you can continue.
So as noted by Dr. Muthumani ma'am, every woman should allot time for themselves, self-care, self-time, and self-love. Only that can, apart from the awareness we try to create, if we want to implement the preventive strategies for breast cancer risk reduction, one has to allot time for oneself. So let me go on to the topic proper. Breastfeeding has been widely recognized for its role in infant nutrition and infant development. We all know that. But apart from the infant benefits, the mother who is breastfeeding the baby also gets some benefits. And the most important benefit the mother is getting is her reduction in having a breast cancer in the later stages of life. And another important point is the infant who has been breastfed is also getting additional protection. That is, infant, when they grow, become an adult, they are also having reduced risk of developing breast cancer. This is one point I would like to highlight in the benefit of breastfeeding. And why this topic matters. Breast cancer, we all know it is one of the most common cancers in women worldwide. By 2040, the expected number of cases in breast cancer is about 3 million new cases, which is in fact a huge number, which we should try to curtail like anything. And mortality is higher in developing countries. Why? Because of the late diagnosis and the limited healthcare access. And the aim of this breast cancer awareness program is to detect cases very early detection. That was what we were talking about over the past 3 days. Early detection. Early detection always carries a pivotal role in bringing down the fatality of breast cancers, as early detection cases are 100% curable. Now, breastfeeding is a factor that can reduce the risk of breast cancer, along with the other potential benefits a mother is getting, like reduction in ovarian cancer risk, reduction in endometrial cancer risk, reduction in the development of all the lifestyle diseases like hypertension and diabetes in their later stages of life. Now, despite the benefits, breastfeeding rates vary due to the cultural, socio-economic, and healthcare-related challenges, which I shall discuss later. Now, coming to the global and Indian statistics regarding breastfeeding, we Indians can be proud about the fact that 58% of the infants under 6 months in India are exclusively breastfed. If you compare globally, it is about 48% of infants under 6 months who are exclusively breastfed. So India is far better. And why we are coming to breast cancer per se? Because in India, the breast cancer accounts for one of the most common cancers in female. The meta-analysis done in 2015 showed more than 12 months of breastfeeding was associated with a reduction in breast cancer risk as well as ovarian cancer risk by 26 and 37% respectively. So this highlights the significance of breastfeeding. This is the picture depicting the same, and the risk of breast cancer is reduced by 4.3% for every 12 months of breastfeeding. So the longer you breastfeed your baby, the more reduction in risk of breast cancer you are having. And this is in addition to the 7% decrease in the risk observed for each birth. Now, let me tell you at this point, what are the risk factors for breast cancer? Early menarche. Menarche is the time when you have the onset of your menses. Your early menarche, your late menopause, you having your first child at a very later stage of life, or your very low parity, the number of births few, or your nulliparity means you're not giving birth at all, or your genetic potentials, or your postmenopausal obesity. These are all risk factors for having breast cancer. So by giving a prolonged breastfeeding to your baby or having more number of births in your reproductive age group, you are reducing your risk of breast cancer. Now, how does breastfeeding helps? That is what we are discussing today. Now, we all know breastfeeding supports the infant intellectually, physically, and all, but it also provides protective benefits to the mother. One of the most important effect is reduction in the risk of breast cancer. The protective effect we have like the more you breastfeed, the greater reduction in the risk of developing breast cancer. That is what the percentage we discussed, 4.3% reduction in risk of breast cancer for every 12 months of breastfeeding. Suppression of ovulation happens during lactation. We all know the breastfeeding time, we call it by the name lactation. So during lactation, you're suppressing your ovulation, your egg production. This is reducing your exposure in the body to estrogen. Estrogen is a hormone which increases the risk of breast cancer. Now, during lactation, that is during breastfeeding, the tissues become resilient to malignant changes. And then during breastfeeding, the cells which have damaged DNA are getting removed from your body. And this is another mechanism which is helping you to protect against breast cancer. And additionally, an immunological modulation is happening in your body. Thus, all this protects the woman against breast cancer. Thus, by hormonal changes, by cellular changes, and by immunological mechanisms, you are getting protected from breast cancer. Now, in some women, we have a gene called BRCA1 gene, which doesn't act properly. So, which if doesn't act properly, this is switching off a helpful gene in our body called FOXA1. This FOXA1 is similar to a healthy BRCA1. We all know when you have mutations in your BRCA1 or BRCA2, you are at threat of developing cancers. So breastfeeding How does breastfeeding helps? Breastfeeding promotes this FOXA1 gene, which is helpful to protect against breast cancer. Now, breastfeeding also removes certain harmful proteins like PAPA-A, which are higher in breast cancer cases. Now, another thing we should know about breastfeeding is we have an oncogene called IRIS. So, the BRCA1 gene is promoting this oncogene IRIS, which is actually too much IRIS can cause aggressive cancers in our body. So longer breastfeeding will help to keep these changes balanced, which will lower our cancer risk. That is, prolonged breastfeeding reduces the harmful oncogene activity and it clears the potential cancer cells. And we have another hormone in our body called prolactin. This prolactin is more during breastfeeding. This prolactin lowers the estrogen. I already told you, your breast, when getting exposed to more estrogen, you are at risk of developing breast cancer. So breastfeeding reduces the level of estrogen in our body with the help of prolactin and other immunological mechanisms, which really reduces the risk of breast cancer. Now, breast milk contains defensive mechanism. It has immune cells, it has antibodies, it has cytokines, which strengthens our body's defense. Another important point about breast milk is it contains a tumor-killing protein called alpha-lactalbumin. It also contains oleic acid, which also triggers the cancer cell death. Thus, during breastfeeding, with the help of all these mechanisms, you are getting protected against breast cancer. Now, after lactation, your breast involutes and becomes normal state. During this process also, all the precancerous cells are removed from the body and we are getting protected from breast cancer. Now, breastfeeding reduces the risk of triple negative breast cancers. You have your breast cancer in different categories. You have positive, hormone receptor positive breast cancers and hormone receptor negative breast cancers. So this triple negative breast cancer is really an advanced aggressive one. So your breastfeeding is reducing the risk of this triple negative breast cancer. And suppose you have a first degree relative having breast cancer. Now you are breastfeeding your baby, you are having a reduction in the risk of, or you are a carrier of this gene BRCA1 mutation. Then if you're feeding more, if you're breastfeeding more your baby, you have a reduction in your lifetime risk of getting breast cancer. Suppose you compare two women having their first degree relatives breast cancer. One is giving her baby exclusive breastfeeding or more breastfeeding. The other one is not breastfeeding her baby. Now, the one who has breastfed her baby has a better risk reduction to develop breast cancer compared to one who has not breastfed at all. That is the greatest advantage of breastfeeding. You're getting protected like anything from this aggressive tumors. Now, this is the chart showing that how the cancer subtypes are getting protected from because of the breastfeeding, how you're getting protected from this aggressive tumors. The immune system always helps to beat against cancer. So breast milk contains immune defense mechanisms which are helping you and protecting you from breast cancer. Now, all these research were done very elaborately, and all these research show that you're getting protected from breast cancer. You have a 4.3% reduction in cancer risk. I'm repeating this for every 12 months of breastfeeding. And all the studies shows that who has breastfed more, like 2 years or longer, or who has exclusively breastfed for 6 months are getting protected from cancer. Now, breastfeeding strongly protects against triple negative breast cancer. This is a highly aggressive tumor. So that much aggressive tumor is also getting reduced because of the risk. The risk is getting reduced when you're breastfeeding your baby. And already mentioned, when you are carrier of BRCA gene mutation, if you are breastfeeding your baby, you are protecting yourself as well as this infant in their later stage from going in for breast cancer. The risk definitely gets reduced if you are breastfeeding. Now, another advantage of breastfeeding is it helps you from the risk is reduced from ovarian cancer as well as endometrial cancer and future metabolic syndromes like diabetes, hypertension, and all. So breastfeeding carries its own benefits. During breastfeeding, what happens is the cell division number is getting reduced. The DNA mutations are getting reduced. So you're getting protected from breast cancer because of the exclusive breastfeeding as well as due to the prolonged breastfeeding. Now, worldwide, American Academy of Pediatrics, the WHO all recommends exclusive breastfeeding for 6 months and continued breastfeeding for up to 2 years or longer. Now, everyone is promoting breastfeeding, but definitely there are some barriers to breastfeeding. And what all the barriers we know? Because we know all the women, once they are delivered, maybe after a period of 3 months or 6 months, they're supposed to go for their work if they're working women. At workplaces, they may not have adequate environment to continue their breastfeeding. So we have to change certain social norms. People may be unaware of the benefits or the advantages they're getting from breastfeeding. So it is our duty to provide communication to the patients. What are the advantages? How long should you breastfeed? If they have a poor family support, if they have a poor social support, you have to encourage the women to continue their breastfeeding and correct all these lacunae. Now, public places do not provide adequate private spaces for breastfeeding. We have to change that system. We have to provide to all the mothers who are breastfeeding in their workplaces adequate space to ensure privacy and continue their breastfeeding. We have to change the health policies. How we can encourage breastfeeding should be thought of, and some new regulations should be brought to the women who are breastfeeding and who are working as well. Then some countries, they're promoting and marketing the infant formula system. So we have to abandon that and go for exclusive breastfeeding for the first 6 months. The challenges and barriers have to be really studied in depth, and we have to implement the systems to promote breastfeeding. The health system has got its barriers. The healthcare professionals also do provide some barriers. All these barriers should be abolished, and the breastfeeding should be encouraged like anything. And call to action. That means breastfeeding has a significant protective effect against breast cancer. So this knowledge should be promoted and propagated in the society like anything. And particularly the aggressive tumors like hormone receptor negative tumors, the triple negative tumors are all, we are reducing the risk by promoting breastfeeding. So we have to propagate this to the community. Let's work together to promote breastfeeding, because breastfeeding really reduces the risk of breast cancer. And call to action should be from the healthcare providers, from the workplaces, from the policymakers, from the family, and last but not the least, the community, as well as the media should include. All our media should give advertisements for exclusive breastfeeding up to 6 months. The people should know what are the merits of exclusively breastfeeding the baby for 6 months. The mother as well as the baby are getting benefited. So the take-home messages include: breastfeeding significantly reduces the risk of breast cancer for the mothers. It is a protective effect. It is influenced by the duration. The more you breastfeed, the more you are getting protected, as well as your infant at a later stage of life is also getting protected. And then promoting and supporting breastfeeding requires awareness, supportive environments. The workplaces should be that supportive to women, and we have to address all the social and cultural barriers. We have to encourage the breastfeeding benefits, the maternal and infant health. The infant is getting benefits, so many benefits, like the immunological mechanisms of the baby is getting developed, the cognitive development, the IQ development, everything is better because of exclusive breastfeeding. And we have to create awareness in the public. We have to promote breastfeeding, and infant formulas should not be that much promoted. Only in certain particular scenarios, we have to hype the formula feeding. In all other circumstances, exclusive breastfeeding should be promoted like anything. So every drop of breast milk counts for you and for your baby. So breastfeeding promotion programs should be from the mass, should be from the media, should be from the public. I hope I have done justice to this topic.
Yes, Madam Chair. Actually, that was very well communicated. Any doubts or any questions? ആർക്കെങ്കിലും എന്തെങ്കിലും ഡൗട്ടോ ക്വസ്റ്റ്യൻസോ ഈ സെഷനെ സംബന്ധിച്ച് ചോദിക്കാനുണ്ടെങ്കിൽ right now you are getting an opportunity to directly get the answer from the doctor. Chief guest Muthumani madam.
It was an informative session, ma'am. Actually, I had told my the people who contacted me in the beginning that I would inaugurate and then I have a function, so I'll just log out. But once I started listening to your session, it's very informative and interesting, and but it was communicated in a very easy to comprehend manner, I would say. Though you used all the scientific terminologies and everything, it was easy to comprehend for all, even a layman like me. Thank you so much for imparting your knowledge in such a beautiful manner. Thank you, ma'am.
Thank you, ma'am, for the nice words. Thank you.
And madam, ഈ ബ്രസ്റ്റ് ഫീഡിങ്ങിനെ കുറിച്ചിട്ട് ഇതുപോലെ സെഷൻസ് അങ്ങനെ എന്തെങ്കിലും കണ്ടക്ട് ചെയ്യാറുണ്ടോ? Because nowadays most of the ladies are not interested in doing that.
Actually, August 1st to 8th, we carry it as the breastfeeding week. So we have all the communication programs, and in a hospital, not only in our hospital, in almost all the hospitals, we have this baby-friendly hospital initiative. So as soon as the baby is born, the baby is being breastfed, and we promote we encourage breastfeeding like anything. We do tell every mother, and including the family members, the benefits of exclusive breastfeeding. Majority of the women we encounter nowadays are working women as well. So they would like to assume
that is a serious problem most of the women are facing right now.
So they normally would like to resume their work 3 months. Some people get the benefit of taking leave for 6 months. So all those who get the benefit of taking 6 months postpartum leave, we encourage them to have the exclusive breastfeeding in the first 6 months. Only then the weaning starts. For those who cannot carry out this, maybe in the first 3 months, they can exclusively breastfeed their baby. And express breast milk, EBM, is another important thing. They can express their milk, and in containers, they can be like kept for 6 hours or so. And they can, in between their work, if they are provided with adequate private spaces, if the privacy is ensured, and they're given a supportive system to carry on with the breastfeeding, the workplaces should see to it basically.
Yeah, that's true.
We should have rules and regulations to promote breastfeeding like anything. Not only for the baby, the mother is also getting benefited. Majority of the women do not know that. Everyone thinks that once the baby is being breastfed, the baby gets the advantage of that. And this is one aspect many of the women doesn't know, that including themselves are getting protected because of the breastfeeding.
Yeah, right. Madam, actually, should we refrigerate this breast milk?
Actually, for 6 hours, if you keep it in glass containers, it's sterile. We can keep it in glass containers in the outside environment in the room temperature for 6 hours.
For 6 hours. Okay.
6 hours.
Okay.
That is when the baby express breast milk. We can encourage that as well.
Yeah. Actually, most of the working women can do that.
Formula feed should not be promoted. In the initial days, latching.
Madam, even beyond that, we can refrigerate and use, no?
Yeah, maybe we can refrigerate and use, but usually we promote this only, keeping it glass containers for 6 hours.
Okay.
Instead of refrigerating.
Sometimes, as you rightly pointed out in the beginning, our legislations and has not been done by the government for promoting breastfeeding for the working women.
Yeah.
Because most of the laws have been previously formed, and at that time the women are not working. Now we see even every family is a double income family.
Yes.
And most of them are working. If we take Kerala, so what we need is laws and regulations for working women, so that they can breastfeed the baby even while working. Since that option is,
then nowadays there are more relaxation for that, right?
The central government employees have a beneficial scheme. They can take more leaves and they can avail the 6 months exclusive breastfeeding program because they have adequate leaves. But unfortunately, the state government employees do not have that much leave. And all those who are working in private sector, once 3 months are over, they get a threat from the workplace that they have to resume their work, otherwise they have to resign and all, including medical professionals. So we have to amend the rules. As Dr. Ansar rightly pointed, amendments should be made. The rules and regulations should be promoting exclusive breastfeeding in the first 6 months postpartum period.
And one of the difficulties, especially the working women doctors, what they face, and the the professionals, nurses and other healthcare professionals, their duty time is 12 hours. So even if they want to breastfeed the babies, they have to express the milk and keep it in the container and go for the work. So I think keep outside, and beyond that also sometimes because of the work hours of extended period, they may have to keep it in some form of refrigeration. That is, Ms. Ponnee was asking whether it is it safe to refrigerate and use the milk beyond 6 hours?
Thing is, baby should not get enterocolitis and all. So ideally, if you ask me, I will encourage only this glass container 6 hours rather than refrigeration.
So that
Basically,
means
newborn immunity, we should not, the gut bacteria, good bacteria are getting promoted because of the breast milk. So the advantage of breast milk, exclusive breast milk, is baby's immunological mechanisms. In addition to the intellectual improvement and all, cognitive IQ development and all, the gut system is getting adequately built up with the help of breast milk.
so that aspect we can actually point out that 6 hours is the maximum time in a breast, the bottled breast milk can be given. So working women has to be given their working hours according to that, so that beyond 6 hours they can go back and feed the babies. So these recommendations actually we can propose to the government,
Right, that's
so
what
that they can implement breastfeeding strategies for working women.
I think 2 points, right? One is for the extension of leave up to 6 months, and the other one, at least half.
Policy, can somebody actually check into the Maternity Benefit Act? Sorry, I couldn't restrain myself from making this remark because as far as my
Madam,
memory
just a minute, can you introduce yourself, ma'am?
myself Muthumani this side. So being a somebody who has learned law and who is largely working in law segment.
Actually, it's not clear, madam.
Ma'am Muthumani this side, can you hear me?
Actually, it's not clearly audible.
Hello, am I audible now?
Yes, madam.
Yeah, madam.
Muthumani ആണ് ഇവിടെ മുത്തുമണിയാണ് സംസാരിച്ചത്. Okay, so basically, as far as my memory goes, Maternity Benefit Act എന്ന് പറഞ്ഞിട്ടുള്ള ആക്ടില് 180 days തന്നെയാണ് കേട്ടോ paid leave ഉള്ളത്. I don't know how far that in the implementation stage എനിക്ക് അറിയില്ല, but theoretically speaking, as far as my memory goes, there
Madam,
is this
is it for the government sector or for both?
I think as of now അത് എല്ലാവർക്കും applicable ആയിട്ട് കിട്ടുന്നുണ്ടെന്നുള്ളതാണ്. And once an employed ഒരു pregnant ആയിട്ടുള്ള ഒരു employee system വിട്ട് പോയി കഴിഞ്ഞാലും, അതായത് maternity break പോയി കഴിഞ്ഞാലും, once she resumes the role, she should be given the same role or equivalent role to what she was handling before she went on to maternity break എന്നൊക്കെ provisions ഉണ്ട്. By and large അത് follow ചെയ്യുന്ന organizations എനിക്കറിയാം. I'm not quite sure എല്ലായിടത്തും എങ്ങനെയാണെന്നുള്ളത്.
Madam, ബാക്കി എല്ലാവരും മ്യൂട്ട് ആയിരുന്നാൽ
ഡോക്ടർ പറഞ്ഞതിൽ ഏറ്റവും ഭയങ്കര എനിക്ക് വേറൊരു പോയിന്റ് ആഡ് ഓൺ ഉള്ളത് കറക്റ്റ് ആണ് ഡോക്ടർ പറഞ്ഞതിൽ ഒരു ബ്രസ്റ്റ് ഫീഡിങ് സ്പേസിന്റെ അവൈലബിലിറ്റി ആണ് ആക്ച്വലി നമ്മൾ കൂടുതലും സത്യത്തിൽ ഉണ്ടാവേണ്ടത്. ഇപ്പൊ നമ്മൾ ചില പബ്ലിക് സ്പേസസിൽ പോയി കഴിഞ്ഞു കഴിഞ്ഞാൽ we don't have a breastfeeding space actually. നമ്മൾ let's assume it's a Sunday ഹോളിഡേ ആണ് എന്നിരുന്നാൽ പോലും നമ്മൾക്ക് ഒരാൾ വർക്കിംഗ് ഒന്നും അല്ലാതിരിക്കുന്ന ഒരു ദിവസമാണെങ്കിൽ പോലും നമ്മൾ വീടിന്റെ പുറത്തേക്ക് പോയി കഴിഞ്ഞു കഴിഞ്ഞാൽ എത്ര പൊതു ഇടങ്ങൾ ബ്രസ്റ്റ് ഫീഡിങ് ഫ്രണ്ട്ലി ആക്കാൻ പറ്റുമോ അത്രയും സ്പോർട്സ് ഇസ് റിക്വയർഡ്.
ഇപ്പോ ഐ തിങ്ക് എല്ലായിടത്തും ആ ഒരു കോൺസെപ്റ്റ് ഇസ് ദേർ.
പ്രൈമറി സ്പോർട്സിൽ ഇറ്റ് ഇസ് ദേർ, യെസ്. ബട്ട് അതിനപ്പുറത്തേക്കും ഉണ്ടല്ലോ പൊതു ഇടങ്ങൾ എന്ന് പറയുന്ന അല്ലാതെയും സ്ഥലങ്ങളുണ്ടല്ലോ. അപ്പൊ
പോയാൽ തന്നെ ഐ ഡോണ്ട് തിങ്ക് ദാറ്റ് we will get a space for that. For government hospitals എവിടെ പോയാൽ
അറിയില്ല, അതാണ് എനിക്ക് അറിയില്ല. അതിന്റെ ഒരു വശം സാറ് പറഞ്ഞിട്ട് ഡോക്ടർ പറഞ്ഞ പോയിന്റ് വളരെ കറക്റ്റ് ആണ്. അതൊക്കെ നമുക്ക് അതിനുള്ള സ്പേസുകളും കൂടെ അതിന്റെ അകത്ത് വളരെ വലിയ ഫാക്ടർ ആണ് അത്.
Baby friendly hospital initiative program states.
Excuse me.
Baby friendly hospital initiative program is there. So it states adequate feeding rooms should be provided in hospitals. So almost all the hospitals provide this.
ഞാൻ എറണാകുളത്തൊക്കെ കണ്ടിട്ടുള്ള ഹോസ്പിറ്റൽസ് ഓൾമോസ്റ്റ് എല്ലായിടത്തും I've seen hospitals are taken care of actually, but
hospitals ഞങ്ങളുടെ ചെറിയ ചെറിയ ക്ലിനിക്കൽ ഫെസിലിറ്റീസിലൊക്കെ പോയി കഴിഞ്ഞു കഴിഞ്ഞാൽ ഇങ്ങനത്തെ ഫെസിലിറ്റീസ് ഒന്നും we don't get. I don't think so.
Oh,
PFHI states it should be provided. Another thing is, ma'am, those who have the ESI benefit gets that 6 months leave, as you correctly pointed, but only for those central government employees as well as those state government employees who have the ESI benefit. Those working in the private sector, this 180 days leaves are not granted. So we have to amend the rules.
And even beyond 6 months, we have to promote breastfeeding up to 2 years minimum.
Yes.
So
Yes.
that means according to that, we have to amend the rules. So 6 hours, up to 6 hours, we can storage the milk and give. But beyond 6 hours, the mother should meet the baby again. So even for working hours of a...
It is not possible to carry the baby to the office, the initial stage. So, or a half day leave, angane vechittu, എന്തെങ്കിലും ഒരു amendment ചെയ്യാൻ പറ്റും. It's better to give 180 days.
Working hours can be reduced. For breastfeeding women.
Yeah, right.
That way we can, so this point we can point out that 6 hours is the maximum duration where the breast milk can be saved, preserved in the normal temperature. So the working hours has to be reduced for the breastfeeding women. That's one thing that we can propose to the government further. The adequate amendments can be made in the current law.
Right. Actually, I think these are the points we can note it down and we can submit it before the government, right?
Yes.
Yeah, that we can do. I think we can move to next session.
One sec. I would like to wish the coming Onco Summit and the very best wishes from my side for the Onco Summit.
Thank you, madam. Thank you. Thank you on behalf of Swasthi and AMMA and IRIA.
Because of the support of these three organizations, this is going on. And moving to next, Dr. Thara Pratap, Head, Department of Radiology, Lakeshore, Kochi.
Yeah, can you just stop? Yeah, I'll just share my slides. Can you see my slides?
No, it's not visible.
Okay.
Yes.
Oh, yeah. So, good evening to all. So, especially to Muthumani ma'am, Ponnee ma'am, and sir, Dr. Anitha, and all other attendees. So, I'm really proud to be part of this program to spread awareness on breast cancer. And I would directly go to my topic proper. So, who should go for breast screening? What are the age limits and what are the risk guidelines? So as we already know, 1 in 8 women have a lifetime incidence of getting breast cancer, and early detection really matters. Why? Because early cancers are small and they are easy to treat, and there is increased chance of cure and breast conservation.
Madam, can you maximize your screen?
Your slides are not, you have to make
Can
it.
you maximize the screen, madam?
Maximized over here, but
you try the slide
maximize from my side, yeah.
Actually, this is not in a PPT format, I think.
How is it now? Is it visible?
No, same only.
We can see up to the first line of introduction.
I'll just share once again.
Yep. Yeah, now it's clear.
Is it?
Yeah, it's visible.
Is it?
Yeah.
Yeah, I'm sorry for the
It's
technical
okay.
glitch. Yeah. So the topic is who should go for breast screening, age and risk guidelines. So as you all know, 1 in 8 women have a likelihood of getting breast cancer. Early detection by screening really matters because early cancers are small and they are easy to treat. And there is also an increased chance of cure and breast conservation if they're detected quite early. And so what is the role of breast cancer screening? It detects cancer 2 to 3 years before symptoms appear or before the lump is palpable. And regular screening can reduce breast cancer deaths by 20 to 40%. So it tells us that screening really makes a difference. So what are the screening tools available with us? We have X-ray mammogram, breast ultrasound for young women, MRI mammogram for high-risk women, and digital breast tomosynthesis, which is a 3D mammogram. So understanding screening mammogram is very important because, as I have already said, early detection would save lives. So what is mammogram? So it is just an X-ray, low-dose X-ray, which is used to detect breast cancer before symptoms appear. And the purpose of early detection is to find out the lump before it can be felt. And the target group is women aged 40 and above. So how does a mammogram work? So this is just like an X-ray machine, and you use low dose X-rays to image the breast. So this radiation is within the permissible limit. And you compress the breast for a few seconds, and then you take 2 images per breast in different positions. You call it top down and side view, so that you can, if the lesion is seen on 2 views, it means that this is really significant. And so these are the 4 views that we take for the 2 breasts together. So 2 for each breast in 2 projections. And this is actually the mammogram of a 45-year-old lady. And you can see that, like, there are some whiter areas and some grayish areas. So the whiter areas are the glandular component and the grayish areas are the fatty components. So in young women, it would be more of glandular component, so that it would be very whitish. And for older women, like, it would be more of grayish. So the lesions would also appear whitish. And so in young women, like, if you do mammography, it's very difficult to pick up the lesions from amongst the dense glandular tissue. And on the contrary, this is the mammogram of an elderly woman, and you can say that it is mostly grayish. So, and this is actually an early breast cancer. So our aim of doing screening is to pick up lesions very early before it is palpable, so that it is curable. And we have several guidelines which is put forward by American Society, by UK guidelines. Then we have this National Comprehensive Cancer Network guidelines. Though we did not have any national screening programs in the Indian scenario, we have several organizations which have come up with guidelines which is suitable for Indian population. And I would say that the Breast Imaging Society of India is one such group which has come up with guidelines which is suited to Indian population. So who should get screened? Average risk women should start screening at the age of 40 with an X-ray mammogram. And this has to be done every year with a mammogram, X-ray mammogram, or you can alternate it with ultrasound if your breast density is high. I'll come to what is breast density. But if you fall under the high risk category, you have to start screening very early, that is by around 25 to 30 years of age. And at this early age group, an X-ray mammogram is not recommended. You need to do either MR mammogram plus minus X-ray mammogram as your age advances. So what makes you fall under the high risk category? So it's your family history and the BRCA1 and 2 mutations, which Dr. Anitha already discussed. So remember, 40 is an important number to start screening for breast cancer for an average risk women. So what I was telling about breast density is that actually these are mammograms from 4 different women. And you can see that this is type A, which is mostly fatty. So this is a type of breast which you would encounter in an elderly population. On the other hand, look at the extreme left. Here you can see that the breast is very glandular. It is more white. So this is the type of breast which you see in younger population. And as your age advances, it would become more fatty. And if you do a mammogram, it will be very easy to pick up lesions in an elderly woman, but in a younger woman, from mammogram alone, it may be difficult to pick up the lesion. So that is why we don't recommend screening mammograms below the age of 40. So 40 is a very important age to start X-ray mammogram. So what should you do to screen if you are below 40? So below 40, as the clinicians have discussed in the previous 2 days, you have to go in for a self breast examination. So that has been dealt with in detail, or a clinical breast examination, because a clinician would be an expert in picking up lesions much earlier and better than you. Or you can do an ultrasound for young women for screening purposes if you are below 40 years. So X-ray mammography is not usually recommended below 40 for the same reasons which I have discussed now. I think I've shown you the images and I've told you that it is very glandular and it is difficult to pick up lesions from amongst the glandular tissue when you are very young. So is there any upper limit for screening? There's no upper limit for screening. You can screen up to 70 or 74 years as long as you are in good health. So if a woman's life expectancy exceeds 5 to 7 years, then you can do the screening. So what makes you fall under the high risk category? So it means that your lifetime risk of getting a breast cancer is more than 20%. And we have some risk assessment tools for that. You have to fill in a lot of your details and then your clinician will do that for you. Online calculators are also there. And so that will tell you whether you are in the high risk category or not. So if you are in the high risk category, because of family history or because of BRCA 1 or 2 positive, you have to start screening early by 25 to 30 years. And as I've already said, it would be with MR mammography plus minus X-ray mammogram as your age advances. X-ray mammography is not at all done before the age of 25. So MR mammogram is done for young women and it is done for high risk categories depending on the breast density. And this is a patient position in MR mammogram. So X-ray mammogram is usually done in standing position or sitting position, and this is how MR mammogram is done. You have to lie prone on the table. So how to prepare for an X-ray mammogram? It can be done at any time, but then if you have breast pain, you can schedule it 1 week after your periods, and do not apply deodorant or powder on the day of scan because that would cause artifacts. And you have to bring previous films if available for comparison because that is very important. So after doing a mammogram, we may also do an ultrasound routinely in many centers because the pickup rate would be high, if you combine a mammogram with an ultrasound, if your breast density is high. So that is why we usually do an ultrasound after taking an X-ray mammogram. So, and remember, for every 1,000 women screened, 5 out of 1,000 will be diagnosed with breast cancer. So screening is very important. So what are the myths and facts about breast cancer? So the myth, all breast cancers will have a palpable lump, but the fact is that early cancers do not have a palpable lump. So don't wait for the lump to appear because mammogram can detect it early, when it is not palpable. So if there's no family history means I am safe. No, not all cancers need a positive family history. And mammograms are painful. Yeah, but then it causes only a little bit of discomfort, which is quite bearable. That would what I would say about it. And some people are really worried about radiation, but then believe me, like, it is within the permissible limits. So radiation is very low. And some believe that breast cancer screening is only for old women, no, because like, more cancers are diagnosed at a younger age. And remember the age is 40 for doing a regular screening mammogram. And remember that all lumps are not cancerous, so don't be very scared about it, because 80% of lumps could be non-cancerous. It could be something like a fibroadenoma, and only women can get breast cancer. No, men can also get breast cancer. Breast cancer is non-curable. No, 90% of early breast cancer is curable with breast conservating treatment. And small size breast would have less chance of breast cancer. Remember, there's no relation between the breast size and cancer risk. And mammogram always finds cancer. It's the best tool. The fact is that it is a best tool, but it's not 100% perfect. And at times it has to be coupled with other tests for a confirmatory diagnosis. So what happens after we do a mammogram on you? So all these films would be reviewed by the radiologist, and the reports would be provided in the form of BIRAT. So we put some categories, and this is for assessment and for follow-up. So if you are very sure that, like, this is a malignant lesion, we would put it as BIRATS 5 in the report, which means that the report, and this conveys everything to the clinician, and the clinician knows that these patients have to undergo true cut biopsy. And if you put it as assessment category 3, it means that this patient has to undergo a follow-up after 6 months. So if you put it as 2, it means only routine annual screening is needed. So after you get the report, either the radiologist or the clinician will discuss with you the findings, and accordingly you should do the follow-ups. So combined radiological and clinical expertise is essential for proper management. And I'll try to answer some of your questions also. So what if you have implants? Even if you have implants, it's generally safe to have a screening mammogram. Like we have special techniques for that. We can just displace the implants and do a proper mammogram. So far I've been talking about screening mammography, and there's something called diagnostic mammography. So both are done in the same manner, only that the terminology differs. Screening means you don't have any symptom. Diagnostic mammography means you have some symptom. Either it could be pain or it could be a lump. So mammogram is taken in the same manner. So if you have a lump palpable, more than 40 years also, it is X-ray mammography. But if you are less than 40 years, you begin with an ultrasound. And if it is suspicious, because some lumps may be benign, and so you can leave it. But if you're really suspicious, below 40 also, you can do an X-ray mammogram if you are symptomatic. And sometimes, like, if you have symptoms only on one breast. So we have seen patients, like, coming for a unilateral mammogram, but it's always better to take mammograms on both sides, because you can look for abnormalities. We usually compare the mammogram of one side with the other side, and then you pick up the differences. So that is very important, to pick up early lesions and architectural distortions. So always a bilateral mammogram should be done even if you are symptomatic only on one side. So after unilateral mastectomy, like, should they undergo follow-up? Definitely yes, because you fall under the high-risk category after having a breast cancer and a unilateral mastectomy. So screening of the contralateral breast is done to look for breast cancer. So what if a lump is detected in pregnancy? The initial modality of choice would be ultrasound, and if that's suspicious, a true cut biopsy should be done. So that's how it is if a lump is detected in pregnancy. So the take-home message would be, mammogram is a quick, safe, and a life-saving screening modality. You have to start regular screening at age 40 and talk to your doctor about the risk factors. So the risk calculation can be done, and if there is a lifetime risk of more than 20% in getting a breast cancer, you need to start screening early. Spread awareness, save lives, and screening saves lives. And as I've already said, 1 in 8 women can develop breast cancer. So mammography detects lesions when it is small, when it is treatable. So encourage everybody, around mothers, sisters, and friends to get screened, because early detection equates with better survival and less treatment. And I hope together we can achieve this. So thank you all, and I'm really proud to be part of this group to spread awareness on breast cancer. And I hope, like, the screening would be made mandatory in our national screening programs as well. So let's hope for that. So I will be happy to take any questions.
Thank you, madam. Thank you so much. Again, that also was a wonderful session. ഞങ്ങൾ നേരത്തെ പറഞ്ഞതുപോലെ ഇതിൽ കുറച്ച് പോയിന്റ്സ് നോട്ട് ഡൗൺ ചെയ്തിട്ട് we took a decision that it's better to submit before the government. അതിന്റെ കൂടെ I think we can add one more point, that mandatory mammogram for all the ladies at the age of 40. അതും കൂടി ഗവൺമെന്റിന്റെ ഭാഗത്തുനിന്ന് ഒരു സജഷൻ നമുക്ക് റിക്വസ്റ്റ് കൊടുക്കാമെന്ന് എനിക്ക് തോന്നുന്നു അല്ലേ?
Yeah, that would be great. Yeah.
കാരണം നമ്മളിങ്ങനെ ഈ സെഷൻസ് വെക്കുന്നതിന് there should be some outcome, right? We are talking this much, and these are the difficulties we are facing. These are the things these are the steps we should take എന്നൊക്കെ നമ്മൾ പറയുന്നതല്ലാതെ what step we can do എന്നുള്ളത് we should finalize.
If we calculate, if we are making a compulsory mammogram for all women above the age of 40 up to the age of 70, and if we calculate the population, we have 3.5, and out of which 1.6 crore, around 80 lakhs, 60 to 80 lakhs women will need mammogram every year in Kerala. So if we divide by that district wise, approximately 6 lakh mammogram has to be taken in every district every year. And a center equipped with mammogram with radiologist can do around 3,000 mammogram maximum per year. So that means we will need 200 centers in every district if we really want to implement a screening strategy for all eligible women in Kerala. So definitely we don't have that many number of centers at present in Kerala. So that is the main barrier that we have to implement a screening mammogram program in Kerala, even if we want to implement that. So that is the most important barrier that we have.
I think this can be introduced in the offices also, right? Because most of the offices are coming up with the health insurance and all. This also can be included in that.
Yeah, opportunistic screening, I think we can go for that in the present scenario.
Yeah, presently what we can practically what we can do
we are
is
getting an idea that how important this is എന്നുള്ളത് മനസ്സിലാകുന്നു. Yes, doctor. I'm sorry.
Presently in the program also we have this state government run program. We have calculated how far we can go with the screening mammogram. So what we can do is do mammogram for high risk women. So our state is only equipped for doing mammograms for high risk women. So we have to identify women with high risk by we have a Shaili app for the government doctors. In this app, we will identify women with a high risk, and they will be referred for screening mammograms. So this type of opportunity screening that we are doing presently in Kerala. Even though it's not a true screening, it will help us to identify more women with breast cancer in an early stage. So that is where we are today. So maybe because of more data comes, we can proceed. We will be moving towards a true screening program in the state of Kerala, and the requirement is actually too huge. 200 centers in every district is not possible in the near future, but that is what is required if you really want to implement that.
How do you identify this high risk?
Early detection, right?
How do you identify
Yeah,
this
Rijo sir.
Okay, I'm Dr. Rijo.
High risk means a positive family history. A woman with more than one first degree relative with breast cancer, or one first degree relative and 2 or more second degree relatives with the breast cancer, breast or ovarian cancer, both comes under the high risk category. Then a woman with a higher risk, if there are previous breast biopsies has been done for benign conditions, if any of such biopsies has an atypia, they are at a higher risk. And the women who have an early menarche below the age of 12 and late first childbirth, where the menarche to first childbirth duration is more, 10 to 20 years. Because if we take a women having menarche at the age of 10 and first child at the age of 30, the exclusive action of estrogen is there for 20 years. So they are at a higher risk of developing breast cancer, even though they don't have any other risk factor. Then postmenopausal obesity. After the periods have stopped, if the woman is obese, they are at a higher risk of having breast cancer. These are the common things which will put the women at a higher risk of developing breast cancer. For those who are nulliparous, unmarried or married but did not have children, or those did not breastfeed the babies, these women will come under the high risk category. Such women can be encouraged for the screening mammograms.
Yeah.
Rijo sir was telling something, sir.
Thank you, sir. Yeah, thank you, Ponnee. See, I have got a different viewpoint from what Dr. Ansar has said. Dr. Ansar, of course, is highlighting the importance of a high-risk group stratification and further workup with the mammogram. But right now, if you look at the mammography centers readily available in Kerala, I don't think everyone is having a lot of cases and they are fully occupied with that. It is a gross underutilization of mammography services, existing mammography services throughout the state right at this point of time. It's only a matter of connecting all these centers, networking with them, and make use of the existing centers itself can improve the number of cases that should be screened. That is one. Second point I would like to highlight is if you're targeting only the high risk group, again the detection rates you may pick up stage 2 and all, stage 3, stage 4 and all. Maybe again the numbers will be a little problematic at that point of time. If you truly want to reduce the if you want to increase the pickup at stage 1 or even before that and increase the survivor quality of life, we need to go for a screening, and we should think of ways how to make it affordable and make it accessible throughout the state for this 67 to 70 lakh population of the 40 to 70 years group, where insurance can be brought in, government activities can be brought in, then the network of mammography centers throughout the state. And as part of this initiative, the Radiology Association is now coming out with a network of centers which are providing the mammography services in every district. Now we will come out with, and we are offering that list soon after this this month of program. So we ourselves have identified there are 70 to 80 centers which are capable of doing mammography throughout the state, and numbers of still can be added into that. We have not utilized the possibilities. Now, rather than worrying too much about the scarcity of the resources, we should be thinking how can we make it possible, or how can we make screening mandatory for 40 to 70 age group of population. If it is 60 to 80 lakh, because Kerala is the one state where this kind of a screening can give very good dividends if you go for a mandatory screening.
Sir, the same thing has been discussed during our state-wise discussion for the screening program, and we have addressed the issue. So presently, the infrastructure we have is insufficient to roll out a complete screening program. So what we can actually do is we can calculate the number of mammograms that presently the entire radiological community and centers can be done, and what is the deficit which we can fill up. And even in the private sector, the mammograms can be done at a reduced rate. So in the government, in the last program, we have suggested a free mammogram for BPL patients in all government centers, and a reduced rate for an APL group of, they are not patients, APL persons, because they are not having disease. We are trying to find out this, if at all if they have a disease, in a healthy individual. So they are not patients. So that we can calculate and propose to the government as an organization and a group. This is the one that we can do. The government said they have identified the deficits and how far the private sector can also contribute and what is the actual deficit if we include the private sector also into that screening mammogram program. That one we can propose to the government.
Yeah, it has to be a public-private partnership. I think government alone cannot do this because the kind of the volumes that we have, especially the private centers, has to chip in a big way, including the small and medium diagnostic centers, small and medium hospitals, corporate hospitals, and the government and tertiary centers also. So it is something that has to a joint venture, and much more importantly, what I feel is there is still there are a lot of centers I know that they don't have enough mammograms, they don't have enough studies coming in. You ask honestly, many of the places they don't get enough number of cases. I know it. So when we say even those centers are not getting it, this the awareness is the main problem, and then some other kind of a motivation to get it screened. Even the high risk groups are not coming there. So there are issues are multifold, and rather than discouraging a screening program which can give a real good quality pickup rates, we should think how we can make it possible with the help of insurance, with the kind of digital network, and with the help of more and more centers being added into that, make it affordable, and there are different ways to get it. So that kind of an action plan has to be designed rather, and of course, for the time being, as a short-term this thing, like what Dr. Ansar has said, we should go for an opportunistic screening of the high-risk group and then get into that stage as early as possible with more and more resources made available. So we should change our thought process to how can we make it affordable, how can we make it happen, rather than saying a no to because of the huge numbers or the less or the scarcity of resources. It is time for us to think in a different direction. That's what my opinion is.
Thank you, Doctor. Thank you. And shall I ask you one thing apart from the layman side? Do we have any other symptom apart from the lumps? Because how this can be identified from a common man's perspective?
The most common symptom is a painless lump, but there can
That's
be
the one thing.
nipple discharge.
Okay.
That is mostly a bloody discharge or a black discharge, and usually from a single duct. That is a second most common symptom, and rarely there won't be any lump in the breast. Instead, there will be a lump in the axilla, in the armpit.
Okay.
And in advanced stages, there will be redness in the breast. There will be orange skin-like appearance in the breast. These are all symptoms. And very advanced cases, if the disease has spread to the bones, which is the most common site of metastasis, patient can present with the back pain also. But if you take overall, it is a painless lump, mostly in the age group of 40 to 60 years. And in Kerala, we have maximum number of cases in the age group of less than 50 years, approximately 50%.
We have some messages
Shall I add a
from,
point?
yes.
Nipple retraction, one has to be careful. You can stand in front of the mirror, raise your both arms and look at the nipples. If the nipple is retracted on one side or on the other side, it may be a pointer towards malignancy. And skin changes, as Ansar told, redness or orange skin-like appearance. You can do a self-breast examination once a month. You can look at the 4 quadrants of the breast with your inner palms, roll on the breast and look at any lesion is there or not. And sir, I have one more doubt to ask you. Suppose a mammogram is detecting BIRADS 2 lesion. Say they are pointing it as fibroadenoma or adenosis. What is the chance of the lesion turning into malignancy? How frequently the woman should not follow? Suppose MR mammogram is diagnosing as BIRADS 2, and how frequently should the woman be on a follow-up with ultrasound or mammogram if the BIRADS 2 is getting diagnosed with an MR mammogram? Totally asymptomatic woman.
I think BIRADS 2 means like, there is very little chance of it being.
Yeah.
There is very little chance of it being malignant. I think the risk of malignancy is less than 3%, and we would recommend just annual follow-ups. So there is
On
recommendation which is
point, I would
given by
like to
the
add.
society. Yeah.
On point, I would like to add what Dr. Thara has said. It's not the mammogram alone that we are looking at. If the patient is more than 60 years post-menopausal and she has a lump, even if we report it as BIRADS 2, still we will keep the patient under a close follow-up. We will recall the patient within 3 months and we will check it again, because in a 60-year-old post-menopausal, we are not expecting a benign condition, because this is not the age of a benign breast disease or benign cyst. Even a cyst can be a hiding a papillary neoplasm in its wall. So a BIRADS 2 in a 60-year-old needs a close follow-up. At a BIRADS 2 in a 40-year-old, it's BIRADS 2. We know there is a time when there can be benign breast diseases. So we have to take into consideration other factors. And most important is the age and menopausal status. And second thing, a very strong family history. If the patient comes and says, my relative or my mother had breast cancer at the age of 50. Now this patient has come at the age of 40. And we did a mammogram. If there is a BIRADS 3 lesion, in that situation, we will not keep the patient under follow-up. We will definitely go for a biopsy, because there the history is more in favor for going a biopsy. If strictly go by mammogram BIRAD score, then only 4 needs a biopsy. So age, family history, and another thing is if there is a BRCA mutation positive in the family, the person, or person's first degree relative, then again we will recommend for an MR mammogram, even if it is reported as a BIRADS 2 or 3. Because there the chance of a BRCA positivity, if it is a mother, there is a 50% chance in the daughter. And we will also request for a genetic testing. So it is not a single step process. It's a multi-step process considering other factors also.
Yeah.
I think now we exceed the time up to 6 minutes.
Okay.
So
Okay.
there are a few questions in the chat box from one Miss Chitra Nair. Are for
fibroadenomas. Fibroadenomas are all benign conditions.
Really
Fibroadenoma is a benign breast disease. It's a harmless disease. But there are certain situations where we have to be very, very careful. A fibroadenoma, more than 4 centimeters in size, or an atypical fibroadenoma with multiple lobulations. In such situations, it need not be a fibroadenoma. Sometimes a phylloid tumor, which is a malignant type of tumor, can mimic a fibroadenoma in imaging. So fibroadenomas in a diagnosis, in an ultrasound diagnosis or a mammogram diagnosis, with no aggressive features, is fibroadenoma. But the fibroadenoma is more than 4 centimeters in size, or it is recently showing a rapid growth, will need a biopsy confirmation that it is fibroadenoma. So in conclusion, all fibroadenomas, benign conditions. But certain other diseases can mimic fibroadenoma, which we have to exclude.
Okay, thank you. Another message from one Miss Anusha. Agree that the optimal use of the existing mammographic centers will go a long way to address the need for the needed screening of women in Kerala. That is her message. And another from Dr. Amilu. Actually, 6 months maternity leave is mandatory now. We need more breastfeeding rooms in public spaces and everything. Then from Sabin Siddiq, how can we help young mothers, especially who struggle with the breastfeeding due to low milk production? Madam, can you answer that?
Yeah, during the antenatal period itself, we can enhance on the maternal nutrition. They have to take more protein-rich diet. Their diet should be 60% of protein, 20% of carb food, and 20% of fat foods. this encourage of taking protein-rich food during the pregnancy itself enhances lactation. And even if in the initial days the milk production is on the lower side, the more time the baby sucks the breast, the more baby's mouth is getting into contact with the mother's nipple, then there is enhanced milk production and reduce the stress. This also carries a pivotal role in enhancing the milk production.
Okay. Then from Dr. Amlu, no ma'am, state government is also giving 6 months mandatory leave. That is what the message from Dr. Amlu. And Dr. Karthikeyan, excellent informative talk, Dr. Anitha. That is a message from Dr. Karthikeyan. These are the messages we received. I think we exceed the time. Now it's nearing to 8:10. So thank you so much. I think the sessions are very informative. Actually, it's clear for us. So again, once again, on behalf of Indian Radiological and Imaging Association, Association of Malayalam Movie Artists and Swasthi Foundation, I thank each one of you, especially our chief guest, Srimati Muthumani, Dr. Anitha, Dr. Thara Pratap, Dr. Ansar, and Dr. Rijo Matthew in this wonderful session. And the session was very informative. Thank you so much. Have a good day.